Hi, welcome all the registrants for this interesting webinar on the topic of widening role of wide field imaging in today's ophthalmology. The wide field imaging has really paved in the ophthalmology practice, and I would suggest not only posterior segment, even anterior segment, and all the ophthalmologists today rely on wide field imaging to a great extent. Today's webinar, we are aiming to understand what these wide field imaging is all about and what are the current available options we have, what are the good things about it, what are the bad things, where our indirect ophthalmoscopy has gone today, the classical way of examining the peripheral retina. We'll also understand the recent advances in the wide field imaging, the role of AI, the newer advances in the optics. We'll try to have some case examples, some case studies on how wide field imaging is useful in many diseases. So I'm Dr. Rajiv Raman. I'm a vitreoretinal surgeon at a tertiary eye care center, Sankara Nethralaya in Chennai. So I will start the first talk. I'll be talking about the clinical importance and the latest advances and the different systems we have for wide field imaging. So today, next couple of minutes, I'll be sharing my views on the clinical importance of wide field imaging, the newer advances, and the various experience of using different systems for wide field imaging. I have no financial disclosure for this talk. So typically, what is defined as a wide field is anything more than 60 degree. So retina, which is extending from the vascular arcades to the posterior edge of the vortex vein ampulla, is called as wide field. And we have another term called as a ultra wide field, where we are able to see from the anterior edge of the vortex vein ampulla beyond to the pars plana. And these are the two types of camera we'll be discussing today, the wide field and the ultra wide field imaging. So why it is important, I'll just start with a simple example. This was a post 45-degree posterior pole image, and some retina specialists may understand that the upper part of the retina seems to be detached. But majority of ophthalmologists may feel that there is hazy view. You cannot make out that detachment. You take a wide field, definitely you can say now the upper part of the retina is detached. And you have the ultra wide field, you can even see the lesions which have caused these detachments. On the upper right, you have a small tear and a horseshoe tear in the upper nasal quadrant. So ultra wide field imaging definitely can pick up these lesions. It can identify what caused this rhegmatogenous retinal detachment. Let's see what advancement have occurred over a period of time. So there are two terms which are often used, the real color and a pseudo color, which is very commonly used with the ultra wide field photograph. This is the classic optos image, ultra wide field image, which used to use the two channels, the red and the green channel, and you get this greenish hue on the retina. And now we also have RGB, the blue channel, which is introduced in these ultra wide field images, and you get the real picture, the true color of the retina. It has advantage that you can see these lesions pretty well. We appreciate what we actually see the retina by an indirect ophthalmoscope. The disadvantage being this blue channel is something which causes one of the advantage of RG channel or optos when it was only RG, it was used, or we tend to use it for children. The blue channel actually causes the photophobia and discomfort, and it becomes a bit difficult for these children to cooperate to get the ultra wide field imaging. So both have their advantage and disadvantage, but that's one thing which has come up. It's not only the pseudo colors, we also have these real colors now. The red channel, which is the 635 nanometer, visualizes the choroidal layer, and we can make out the choroidal pathology to some extent. And we have the green channel, which visualizes the retinal pigment epithelial structure. Classically, we used to call these as the red-free images. And looking at RP function, there are these images, the ultraviolet field imaging has today autofluorescence, it has fundus fluorescein angiogram and indocyanine green angiography features too. The early ultraviolet field imaging also started combining it with multimodal imaging, mainly the spectral domain OCT, the Montana, and we could get a nice posterior pole and the disc OCT along with the optos image. The system had a very good registration, had good segmentation, and was taking nice scans up to 9 to 12 millimeter scans focused on the posterior pole. More recently, we have these ultra-wide field systems which are integrated with swept source OCT, making it possible to look in the OCT images, even in the far periphery, the ultra-wide field images, and looking at these peripheral lesions, what exactly these lesions look like. The big challenge always has been balancing the resolution versus the field of view. The left image, which you can see, is the optos image. The right is another camera. And you can see the resolution of the right is definitely good. However, the field of view is less. So the challenge today has been balancing these resolution versus the higher field of view. Let's see what is there in the pipeline in next few years. People are trying to improve the image quality, the resolution, the field of view. There are a lot of algorithms, AI algorithms and ML algorithms, which have been trying to integrate it with wide field imaging. We want to make these wide field imaging more portable, accessible, and the imaging speed increase in the speed so that we can enhance the patient comfort. And as I shown initially, we are having more of multimodal imaging. At present, we have only the structural devices like structural modalities like the OCT, FFA, ICG, autofluorescence. But the future is looking at even the functional imaging integrating into the wide field imaging. So uh, there are certain advances which are happening to improve the image quality. These are still in research and people are trying to improve the image quality using these. This is one of them, that there are now pipelines, the AI-enabled pipelines to correct the 3D distortion, especially when you are trying to warp the image where you want to have a multicolor imaging of spectralis, you have an ultra-wide field image and you of a optos and you want to warp them, want to align them properly. The problem, what happens with the conventional method is the peripheral retina, the alignment is not that great. And now we have these AI-enabled pipeline which can create a very nice alignment so that you can have a much better structural correlation. There are now majority of the ultra wide field. I'm not talking about wide field, but majority of the ultra wide field systems are today mydriatic. That means you need to dilate the pupil to get the images. There is also now work happening on non-mydriatic ultra wide field diffraction limited retinal imaging. There are some evidences that we can still create a good wide field image we can get even in a non-mydriatic mode. This is something which is happening today. Traditionally, these ultra-wide field lenses systems have got array of lenses, some prism, so that the peripheral retina could well be visualized. And that makes the peripheral view a bit hazy as compared to the central view. And meta lens is something which has been used in other specialties, other domains. It's made up from metamaterials, which are actually nanostructures, and they are thin lenses which can really be used to improve the quality of image. There are evidences, there are research happening to integrate these meta lenses into the ultra wide field imaging. The big challenge of majority of these ultraviolet field imaging is the presence of media opacity, presence of cataract, and digital ray is a concept which is used in radiology, where using generative AI, using generative adversarial networks, we can actually construct these images so that we can enhance the retinal view in presence of a cataractous lens. And that's something which the research as far as the ultraviolet field imaging is going towards. And Dr. Paul Chan group has really worked in Chicago and tried using trans pars plana illumination rather than a transpupillary illumination, which definitely can get rid of many of the artifacts. That's something, the proof of concept has been published, and people are trying to work on this concept to create ultraviolet field imaging. Last couple of years have been really, I would say, AI algorithms have really paved way. And you look at PubMed every month, there are many articles coming on trying to develop AI algorithms to detect a feature or detect a disease. Diabetic retinopathy has been the first one, and people have tried very accurate algorithms which can detect not only presence or absence, but even the stages of diabetic retinopathy. There have been AI algorithms which are able to look at the morphological characteristics of retinal vessels in high myopia. On fundus fluorescein angiogram, we can now estimate the amount of non-perfusion areas. The ischemic index, which at some time became not so popular, again gaining more popularity in retinal vascular disease. We can quantify them using these ultraviolet field fundus fluorescein angiogram. The diabetic macular edema, there have been image processing work where they tried looking at the retinal vascular bed area and correlating it with the outcome of diabetic macular edema treatment. Definitely peripheral retinal degeneration, AI has been applied, and trying to detect these peripheral lesions has been really good. Not only the retinal conditions, but even many of the systemic conditions like chronic kidney disease, anemia. People have tried making these AI algorithms using ultraviolet field imaging, which can detect these conditions. Let's look into what are the available cameras we have for doing ultraviolet field imaging. Broadly, we can classify them that there are the classical cameras, even 45-degree cameras, which can create montage to give a field about 90 to 100 degree, making it a wide field photograph. And we have those cameras which give these images as a single field. We have again montage. There are many of them now having auto montage facility. However, still the older 45-degree cameras, the Canon, they all have manual montage, like you need to stitch these images to get a larger view. Single field, you have the contact. Mainly, we've been using it for neonates in ROP screening, the RedCam and the Forus Neo. The Heidelberg Engineering Spectralis, also using a contact 110-degree images you can get. The non-contact ones are the Optos, the IDON, the CenterView, the Zeiss Claris systems. And from China, we have M-Optem and Visinix systems, which can definitely give us ultra-wide field imaging using a non-contact system. All of them seems to give good quality images. However, there are certain limitations for all of them. Optos, definitely these peripheral distortions are the problem, and the eyelash artifacts. Peripheral distortions to some extent have been solved. They have now ProView software, especially for fundus fluorescein angiogram, which takes care of these peripheral warping and distortions. Claris, again, the problem has been this vignetting, the peripheral shading, which happens in the peripheral part of the retina. The brightness tends to decrease at the edge of the retina. IDON seems to be a good camera, giving a because it uses a confocal system, but definitely one might struggle with the media opacities and cataract. These cases, the image quality will become very bad. So I have a question, a quiz, and I want this webinar, people should participate, and let's see uh, which of the following statements about wide field retinal imaging is correct. So we have the Optos, Daytona, the California, and Silverstones are the example of contact-based single field imaging system. Zeiss, Visucam, Topcon, Nidec are capable of performing auto montage. The Canon CR2 offers an automated montaging system. And the fourth, in manual montaging, the field of view typically is over 20 degree in a single capture. Great. So majority said that they are capable of performing auto montage. That's true, actually. So let's see what is the clinical importance of getting these wide field images. Definitely, it has role in, I would say, majority of retinal diseases, especially in retinal vascular diseases, peripheral choroidal lesions, uveitis. It has a major role because many of the lesions are in the mid-periphery and periphery of the retina. It is having role in retinal dystrophies, in retinal detachment, pediatric retinal diseases. And if I take overall children who are very uncooperative for doing a peripheral exam, these ultra-wide field images are definitely a boon. In post-operative cases where the view is a bit compromised, again, ultra-wide field imaging plays a role. Retinal dystrophies, it has definitely because we can visualize the peripheral retina. Even in presence of media haze, where you are not able to visualize the entire retina, by doing ultra-wide field imaging, we can look reasonably good quality of image we can get. It's been used for teleconsultations, and the Jocelyn Vision Network in Boston has been using it for tele-screening for diabetic retinopathy. We now know that we have a lot of information in the peripheral retina as far as fundus fluorescein angiogram, and more evidences are coming up for the peripheral OCT features which we can identify. Can be used definitely for counseling and education, and it's a very valuable tool as far as research and medical teaching is concerned. Let's see some role in various diseases, and let me start with diabetic retinopathy, retinal vascular disease. So definitely more than 7 field, if we try to look at the retina, we will identify more lesions. And how it translates in 10% cases, the severity scale of DR increases when we consider peripheral lesions too. This was a study which we had done, a multicentric study from India. And what we found that a third of diabetic retinopathy has what we call as PPL, which is predominantly peripheral lesions. Now that is interesting because these lesions with a traditional fundus photography would often be missed. And these are mainly in the temporal quadrant. Dr. Paul Alelo and group, a couple of years back, they tried looking at that those patients who have these peripheral lesions, if we try to follow them for 4 years, what happens? And they found that in presence of PPL, they have 4 times more risk of progression to proliferative diabetic retinopathy. Now that becomes important, that looking at that peripheral lesions are important because these are the patients who may develop PDR more commonly. We also tried comparing uh, two wide field cameras to understand that in diabetic retinopathy, we are more interested in the resolution of image. You want to have a better resolution or you want to have a wider view. So definitely the quality of image to identify the posterior lesions versus peripheral lesion differ among the cameras. This is what we had published. And we also looked at that wide field image. If we have the agreement amongst a senior ophthalmologist or a retina specialist, there is a disagreement in grading diabetic retinopathy in nearly 15% cases in ultra wide field image. And that's more in cases of early stages of diabetic retinopathy. Traditionally, we knew that peripheral retina, if we see a lot of hemorrhages, we used to suspect, or mid-periphery hemorrhages, we used to suspect that this patient has probably, that was one of the feature of ocular ischemic syndrome. And we tried looking at in diabetic retinopathy, do we have any correlation between the peripheral lesions and systemic comorbidities? And we did find that there is higher prevalence of coronary artery disease in patients who have predominantly peripheral lesions. And then came this landmark study, which tried looking at the risk of diabetic retinopathy worsening, whether the wide field photograph is important or the angiogram is important. So what this study found that the risk of worsening of diabetic retinopathy or treatment was not associated with color fundus PPL, or predominantly lesion, peripheral lesion, but it was more associated with fundus fluorescein PPL. Now, this was contrary to what Dr. Paul Ailello group initially showed. And they found that the eyes with FAPPL had 1.7-fold more risk of worsening over 4 years. Again, can we rely on the fundus photograph alone? Answer was no, because 36% had disparate grading. There were different grading for PPL in FA and on fundus photograph. And which fundus fluorescein feature was more predictive for progression was increasing retinal non-perfusion. That was the feature on FA, which was associated with progression of diabetic retinopathy. Is there any correlation with macular edema? If there is more peripheral non-perfusion, or we have more CNP areas in the periphery, is there any difference in the macular perfusion? And this was with our study, a multicentric study, we showed that eyes with PPL definitely don't have worse macular perfusion. So it is unrelated to macular edema. So why we use ultra-wide field imaging in diabetic retinopathy? There are a couple of reasons we use. One is sometimes we can precisely target the pan-retinal photocoagulation. And again, to assess the completeness of PRP, whether you need a more fill-in or additional PRP if there are skip areas, definitely a wide field image gives a good information. The Widefield fundus fluorescein angiogram, definitely we can understand how much is the non-perfusion. In clinical practice, we routinely don't calculate the ischemic index, but definitely there are features like perivascular leakage, one of the newer signs which have been described as a measure of ischemia, and the capillary non-perfusion, which are peripheral leakage. Perivascular leakage is also a feature of is an inflammatory marker, which serves as a purpose when we are dealing with a poor responder of diabetic macular edema to anti-VEGF injections. So I have another question now, and this is regarding diabetic retinopathy and PPL. And in the context of wide field imaging for diabetic retinopathy, which of the following statement is true regarding the impact of PPL? So PPLs are primarily located in the nasal quadrant. So you have to give the correct answer. You have to give which of this is true. The eyes with FA detected PPL have 1.7-fold increased risk of disease worsening in 4 years. The presence of PPL significantly worsens the macular perfusion with non-proliferative diabetic retinopathy, and color fundus based PPL detection has been proven to be superior prognostic value as compared to FAPPL. Great. So I think majority of you have understood correct that FAPPL seems to be more important than the color fundus PPL, though we should not underestimate the value of color fundus also, because it does give us certain information which I had shared initially. So that's the correct answer. So let's see some examples where wide field imaging has really made some difference. It helps us to see more, as I showed in diabetic retinopathy, many other diseases. This is a case where if you look at this one small fibrovascular polyp in the infranasal quadrant, it seems to be proliferative diabetic retinopathy with macular edema. See a wide field, you can see a wide network of vessel, a very active NV in the supranasal quadrant also. So we see more lesions. Another patient who had this subretinal gliotic change, some RP alterations on the posterior pole, and you get a wide field image, you can see the subretinal fluid, a exudative detachment suggestive of a central serous retinopathy in this eye. And the other eye, so this you can see more clearly, and the other eye also suggestive of changes of chronic CSR. So definitely we can see more. We can even see better. So I'll share two examples, and one is a very interesting kid, a kid who came to me in my OPD with this type of a picture, about 10-year-old boy, and had this massive exudates in the periphery. On looking at this retinal image or with this patient, the first thought was I'm dealing probably with some Coats disease or some exudative detachment in the lower part, having some more exudation in the periphery. When we looked in the other eye, this was the picture, but in the periphery, there was retinoschisis. There were areas of retinoschisis. And if you zoom in, you can see the typical bicycle wheel pattern of the macula. And that gave a suspicion, are we dealing with X-linked retinoschisis? X-linked retinoschisis can present with peripheral exudation. This patient underwent a ERG with the typical negative waveform. We confirmed. We also did genetic testing and confirmed. His brother also having a similar problem. So it's not only the periphery, but sometimes we can even see the posterior pole, a zoomed in image we can look into and get a clue as far as diagnosis is concerned. This is the fundus fluorescein angiogram. The left eye and right eye, we didn't have those telangiectatic vessels, but we had the skytic retina in the lower part and massive exudation. Another interesting case, which was shared by one of my colleague, Dr. Vatsal Parekh from Mumbai, who has the OCT system, the swept source OCT system, which can detect the peripheral lesions. So this was a young boy who was a high myope, and dad had a retinal detachment, and he came for a retinal evaluation. The wide field imaging showed this peripheral lesion very typically looking like a horseshoe tear. And when he got the swept source OCT through that area, it was an enclosed oral bay. So he was planning a laser. At the moment the OCT was done, it was just an enclosed oral bay, didn't need any laser. So this shows how important, because definitely in young kid with no posterior vitreous detachment, you are a bit hesitant treating unnecessary, because that can also induce a PVD causing a retinal detachment. But one must understand that these peripheral retinal imaging are definitely added a great value in our clinical practice, but it cannot replace indirect ophthalmoscope. I'll share this with an example. So this was a case, was high myope, again lasered outside. And if you see the ultra wide field imaging, infranasal quadrant, you can see a small pocket of subretinal fluid, and you can see some laser marks on both the sides of this lesion. We took a little more deeper image, and we could see that there were lattices which were well covered, but there is one pocket of subretinal fluid. However, we were not sure where the break is. A good indirect ophthalmoscopy and a fundus drawing could show that there was a meridional fold with a small hole in the periphery causing this small detachment. So definitely it's not that it can replace a good indirect ophthalmoscopy with the depression. And I would just conclude by saying that definitely a good retinal examination that forms the core of our specialty ophthalmology. Though we have these wide field cameras, one should not forget doing indirect ophthalmoscopy and getting the best out of it. I would like to thank my team from Nethralaya to help me do this, make this presentation. Thank you very much. Thank you. I think we'll start with the next talk, and we have Dr. Raj Lakshmi. Dr. R. Rajlakshmi, she's a senior consultant ophthalmologist, retina specialist with over 2 decades experience in managing eye disorders. And the unique thing is that she works in one of the world-renowned diabetes center. So I would say, seeing diabetic retinopathy, no one can match her experience. She's one of the few ophthalmologists who has also done her PhD. Welcome, Dr. Rajlakshmi, and she would be talking to us more about, so we understood what wide field imaging is, and I touched about some of the future aspects. She'll be going a little more deeper on what is the future of wide field imaging, what's the role of AI-driven diagnostics, and the multimodal integration. Dr. Rajlakshmi.
Good day to all of you. I'm going to be speaking to you about the role of wide field imaging and artificial intelligence. I have no conflicts of interest or financial disclosures to make. We are all aware that over 540 million people worldwide have diabetes, and 3 out of 4 people with diabetes live in low and middle income countries. Any individual and every individual with diabetes is susceptible to developing diabetic retinopathy. Diabetic retinopathy is the 5th leading cause of blindness What is most important is that it is the most common cause of preventable blindness. Early detection and timely treatment, we can prevent blindness due to sight-threatening retinopathy. So, we all know that the American Diabetes Association has mentioned that annual retinal assessment is recommended for all people with diabetes, whether it's type 1 diabetes or type 2 diabetes. And the people with diabetes are not going to come to us ophthalmologists unless they have a complaint. And very often people with retinopathy are asymptomatic. Their main point of contact is going to be their physician or their endocrinologist. So this is the situation where fundus photography has become accepted as a standard for diabetic retinopathy screening. So fundus photography, irrespective of whatever camera that we all use, it is an integral part for diagnosis of retinopathy, documenting the retinopathy lesions. It helps us in making decisions as well as follow-up of our patients with diabetic retinopathy. While this standard single field fundus photograph is what we very often see in many of our clinics, etc., the ETDRS standard 7-field fundus photography is considered as the gold standard for various studies and clinical trials. As you can see, it gives us a nice big picture. However, a 7-field fundus photography is more time consuming. If there is a possibility to have a wider view of the retina, which is covered in a lesser time frame, it would be more comfortable for the patient who's undergoing retinal imaging for routine retina DR screening as well as management. For instance, this side you have a 2-field montage image with which would definitely take lesser time than a 7-field fundus photography. So Dr. Rajiv has already told us about the posterior fold, the conventional fundus photograph with the mydriatic or non-mydriatic camera, which just covers the center. This is covered by the wide field image or the ETDRS 7-field photograph. But the ultra wide field image gives a much wider view of up to 200 degrees field of view. But what none of the present imaging systems have is to aura to aura imaging of the entire retina with a single acquisition is something that we don't have as of now, and we will never know. We could probably get it shortly down in the future. So ultra wide field imaging can image up to 100 to 200 degrees. It covers 80% of the surface of retina in just one click. Whereas a normal single field 45-degree or 50-degree image just covers up to only the central 15-degree alone gets covered. There are studies which have shown that ultra wide field imaging has agreement with the standard 7-field imaging with respect to diabetic retinopathy grading. It reduces, see, a normal non-mydriatic conventional camera which is used for screening, there are a lot of ungradable images because of the non-mydriasis, whereas the amount of ungradable images has drastically reduced with the use of ultra-wide field imaging with scanning laser ophthalmoscopy. It is also attractive because the patient need not get dilated. Nowadays, our patients don't want to get dilated because they want to use their smartphones with dilatation. They can't see their phones, so they prefer not to get dilated. And particularly in our center where we see a lot of patients with long-term diabetes, because of long-term diabetes, autonomic neuropathies, they don't get dilated too well. They have very poor mydriasis. So non-mydriatic ultra-wide field imaging with scanning laser ophthalmoscopy is a boon in such patients, where with conventional cameras, we can't get good quality images in such patients with poor mydriasis. So let us understand what a ultra wide field image would look like. If this is the standard ETDRS image with the 7 fields, anything beyond that, which goes up to the vortex vein ampullae in the 4 quadrants, this provides us with a 200-degree field of view. So I think Dr. Rajiv has been talking about PPLs, predominantly peripheral lesions. In diabetic retinopathy, what gets covered by an ETDRS photograph is the predominantly central lesions. So what is predominantly peripheral lesions? These are the same clinical signs of diabetic retinopathy like microaneurysms, dot and blot hemorrhages, irmas or new vessels, etc., which are seen outside this ETDRS field. Anything you can see on this picture, multiple changes that you are seeing outside the ETDRS field. So here, what gets covered in a wide field image is up to 60 to 100 degrees can get covered in a wide field image when compared to a ultra wide field image. A montage covers a little more, up to 90 degrees with a wide field image. This is one of our patients where you can definitely get the big picture. Of course, the same patient with Optos get a much wider field of view. Similarly, this is an image of taken with a non-mydriatic fundus camera, which does show the posterior pole with macular edema, whereas you get a wider field of view with new vessels seen on Optos and a much clearer, higher resolution image when we take it with a wide field fundus camera. So these are the various cameras which are available. I think Dr. Rajiv also spoke about the montage of the various cameras. We have multiple cameras available with various fields of view, wide field cameras starting from 60 degrees to 100 degrees, ultra wide field cameras from 100 to 200 degrees. Each of these cameras have their own advantages and disadvantages. And the main, as far as countries like India is concerned, which is not everybody can afford to have an ultra wide field camera, and we are also equally interested in looking at low cost alternatives also when we have to do wide field imaging. So we have Optos, we have Spectralis, we have the Zeiss Claris image, Ideon, RedCam, the Remedio Pristine, and the Remedio Pristine 1.5, which is just with 1.5 millimeter pupil also imaging is possible. And these, some of them have a pseudo color like the Optos Diatom Plus, and some give the true color like Claris or Ideon. And these are the various, each one of them having their own advantages and disadvantages. We did a study at our center to see what is the actual role of wide field imaging and ultra wide field imaging in assessment of peripheral lesions in diabetic retinopathy at our patients. We had a smartphone-based wide field imaging camera called the Vistaro camera, and we wanted to compare the lesions picked up, the retinopathy assessment by this camera versus the Optos Diatom Plus camera. So before we proceed, I want to ask a question to all of you, because we've been hearing Dr. Rajiv speak about peripheral lesions, and I also told you what are the peripheral lesions in diabetic retinopathy. So it's time for all of you to again answer this quiz. So which do you think is the most common peripheral lesion that you see in diabetic retinopathy? So let the poll start. Is it retinal hemorrhages, or do you think it's the hard exudates, or cotton wool spots, or venous bleeding? 67% of you have got it right. Yes, it is the retinal hemorrhages. When we speak about retinal hemorrhages, it also means that we are speaking about intraretinal hemorrhages, dot and blot hemorrhages, flame-shaped hemorrhages, etc., which are more commonly seen in the periphery, whereas you see hard exudates, cotton wool spots, etc., more towards as central lesions. So I'll come back to our study that we did at our center. Firstly, all our patients with diabetes, type 2 diabetes, they underwent a non-mydriatic fundus photograph with the Optos Diatom Plus camera. This was followed by mydriatic fundus photograph with the Remedio Vistaro camera, which is a smartphone-based fundus camera, which helps in taking a 60-degree field of view of image. So a single field macula-centered image of Optomap with by Optos was compared against a two-field montage of Vistaro images taken on Vistaro camera. And the images were graded by senior retina specialists at our center. And sight-threatening diabetic retinopathy was defined as presence of severe NPDR or PDR or diabetic macular edema. What we found out was both Remedio Vistaro camera or Remedio Pristine camera as well as Optos Diatom Plus camera had a very high sensitivity as well as specificity in detecting sight-threatening DR. The sensitivity and specificity was about 90% in detecting sight-threatening retinopathy, irrespective of whichever device was used for. And the kappa comparison between the graders was quite high, above 0.8 for the grading between the graders, the two retina specialist graders who graded the fundus images. what we found out was that in ultra wide field imaging, more than almost 50% of the eyes had, because it was all people with diabetes, long-term diabetes, we had 50% of them having peripheral lesions which was picked up by ultra wide field imaging, and about 30% of eyes, that is 27.9, 30% of eyes, PPLs were picked up by wide field imaging. In both these devices, peripheral lesions were more common in the supratemporal quadrant. And as I mentioned earlier, intraretinal hemorrhages was the most common peripheral lesion seen in this particular cohort. Although PPLs were more detected much more by ultra-wide field imaging due to the wider field of view. Automatically, that has a 200-degree field of view versus a 90-degree field of view in a wide field image. It did not translate to differences in the detection of sight-threatening retinopathy between these two systems. So this is a graph which shows the distribution of PPLs in this study across the varying grades of severity of DR. We found that this is where it is showing with thorough camera and Diatenna plus camera, the peripheral lesions seen. None of the no DRs had any PPLs. None of the no DRs had any peripheral lesions picked up on ultra wide field imaging, whereas even the mild NPDR started having peripheral lesions detected. And you can see that the prevalence of PPLs increased with increasing severity of DR by both the cameras. More than 80% of the eyes with severe NPDR and PDR had PPLs detected on ultra-wide field imaging. So, and the wide field imaging also could pick up PPLs to a fair extent. So, I mean, at least rather than not picking up any PPLs, and Dr. Rajiv did mention about the importance of PPLs, that PPLs do indicate a risk of progression quickly to PDR by almost 4 times. So that is the importance of detecting PPLs by doing a wide field or an ultra wide field imaging. At least if there are institutions which cannot afford to buy ultra wide field cameras, a cost effective way of still using could be using such smartphone based wide field cameras. So this camera which we evaluated is now the Remedio Pristine camera. You can see that the montage gives a high resolution image with a horizontal view of about 90-degree field of view and a 58-degree field of view vertically, showing the various lesions quite clearly. This is the Optos fundus photograph of the same patient which I showed you in the previous slide. Here, the only disadvantage with Optos is because of the pseudo color, small subtle irmas can get missed, small subtle microaneurysms because of the pseudo colors may not get picked up. Of course, now you have the latest Optos Diatenna Plus, which also has the RGBs. So you have the red, green, blue. So those disadvantages which I just mentioned because of pseudo color may not be there with the latest Optos Diatenna, which has the RGB colors. This is the latest Remedio Pristine 1.5. So even with a 1.5 millimeter pupil, it may not even be a 2.5. Normally for ultra wide field imaging, they said a minimal pupil dilatation of 2.5 millimeters is required. With a 1.5 millimeter pupil, this camera also has only pseudo color images, but using AI, it is generated into true color images, and you can see that the resolution is almost quite good, like the other high-end ultra wide field cameras. So the advantage of ultra wide field fundus fluorescent angiography, I would like to re-emphasize what Dr. Rajiv mentioned. You can see that the posterior pole does not have many new vessels, whereas the new vessels start appearing more beyond the posterior pole, and with ultra wide field fundus photography and for fundus fluorescent angiography, the areas of non-perfusion are so much seen, so much clearer on these images, and the ischemic index can also get calculated. The staining of the blood vessels so evidently made out. The areas of non-perfusion in the periphery are so very well detected by ultra-wide field fundus fluorescent angiography. So, and this is one of our patients where even after a good PRP follow-up visit, we see this patient who has pre-retinal hemorrhage and a vitreous hemorrhage. And this big picture gives us info whether the peripheral PRP laser has been done adequately and whether this patient has any further skip areas. It helps us to document and confirm whether the periphery has been treated adequately or more supplemental PRP is required when we follow up and treat our patients. So whenever we talk about DR detection, it is essential to understand that it is not just possible with ophthalmologists examining patients or using these high-end cameras. We do need the use of teleophthalmology, and teleophthalmology-based screening for retinopathy is a viable option which is being followed globally, because even just by retinal evaluation of the retinal images very remotely by human graders or is possible, and it is reliable and a cost-effective option. It has been already been proven by various studies. And main thing is the patient need not travel, so it decreases the cost of travel. And because retinopathy, regular repetitive screening is required, teleophthalmology is a boon in that way. If in this teleophthalmology practice or telemedicine-based screening, ultra-wide field imaging is more attractive, because when we did teleophthalmology, I think in the earlier days, we found that with non-patriotic imaging, there were a lot of ungradable images. But with ultra-wide field imaging, the amount of non-gradable images is much lesser. Just with a single click, a wide area of retina is covered, and it causes less discomfort to the patient with RG imaging. And along with this, if there is an automated approach that is using of AI to and deep learning algorithms to detect referable DRs and sight-threatening DRs, even with ultra-wide field imaging, that is going to definitely help reduce the burden of on the healthcare systems for detecting sight-threatening diabetic retinopathy. So let us see how artificial intelligence actually works. So whenever there is, irrespective of whether it's a standard conventional camera image or whether it's a wide field camera image, when the cameras have the images are fed into the AI system, it can be the OCT images or the Avta images or a fundus photograph, and AI pre-processing of the image occurs, AI processing occurs using the convolutional neural networks. The images are basically the annotated images they are first provided for training the algorithm. The algorithms are trained to first detect the grading of the severity of DR. Then there is an internal validation done using the rest of the images. Then an external validation is done. And then finally, the deep learning algorithms actually provide an output saying whether it is a referable diabetic retinopathy or a non-referable diabetic retinopathy. So that is the role of having an artificial intelligence algorithm. So as early as in 2017, we used Remedio fundus on phone camera with IART software, which is an automated artificial intelligence algorithm which can detect sight-threatening retinopathy. And we found that it could detect sight-threatening retinopathy with great sensitivity and specificity. So there are many such algorithms which are available in the market, some of them which are right now in clinical use. The first one to get US FDA approval was the IDX, which is now called the Luminetic score. It got the US FDA approval in 2018, and with it has a very high sensitivity and specificity to detect more than mild NPDR. The IART software that we use is also US FDA approved now, and since 2020, and it is also being used in primary healthcare centers. We have the Google ARDA, which is being used in India and in Thailand. There's a CE mark device. The Selena, which is used by, which was developed at Singapore. It detects not only DR but also ARMD as well as glaucoma. We also have the Meteos AI. Meteos AI is also being used in India and in Europe. The main advantage is that it is an offline AI, in the sense that even in the absence of internet, the AI works. And now Meteos AI is the first AI which has got the approval from the CDSCO, that is the approving authority in India for DR detection. So that is the first thing that has happened in 2024 very recently. So, and the latest AI which got another AI which got US FDA approval is the AIDDS, which has also been approved for by US FDA for with handheld fundus cameras. So similar to what I showed you earlier in the previous slide was AIs which were being approved with conventional retinal images. So, but with ultra wide field images, it requires more specialized knowledge, because one thing, there are some lesions, central lesions within the ETDRS field. And there are 5 fields in the periphery where again the grading of the lesions needs to be done. It is labor intensive, it is time consuming to do grading of ultra wide field images. So definitely an automated grading of ultra wide field images using deep learning algorithms will be very useful. There are different approaches to it which are being done. One is either using, there are some algorithms which have used just the ETDRS area alone and then try to have heat maps to show the lesion areas. Some of them have combined it with, as Dr. Rajiv spoke about, multimodal imaging. They combine Octa's images with Octa and then provided outputs as to whether it is a PDR or NPDR or no DR, etc., based on both Octa's photography as well as OCTA merged as multimodal images. So let us look at some of the deep learning algorithms for referable DR with ultra wide field retinal images. Most of the work which has been done with deep learning algorithms that are AI based detection with ultra wide field images have been done mostly with Optos camera images. It was iRead, which is iRead is again from INAC. They again used Optos images to detect referable DR, and there was one which just detected hard exudates and drusen with the ultra wide field images. That was a study done. And Ting et al., they looked at multimodal images, multimodal imaging with both Optos ultra wide field images as well as OCT together. So it could detect both DR as well as DME. And multimodal imaging deep learning algorithms outperform ones with just single mode imaging. And this one where I think this is a multicentric with study by Tang et al., where they used 3 CNNs and they found a very high sensitivity and specificity to detect sight-threatening retinopathy. And one of the main things is that as of now, none of the deep learning algorithms which are used with ultra wide field images have been approved by US FDA as of now. Probably down the lane, these algorithms would also get US FDA approval. So what is the advantages of using AI in telemedicine? It is mainly because the accuracy is much higher when compared to human graders. The time taken is very less. And the time is saved for the patient also, because the patient need not travel to meet the ophthalmologist. It is cost effective because it saves cost of travel for the patient, and even it is scalable in the sense that now we are going to have the World Diabetes Day on November 14th. If there are about 1,000 patients who are seen at a camp, with use of AI, within no time we can get the output of results of how many DRs have been seen once the images are uploaded for AI automated diagnosis. And this is going to help in timely detection of sight-threatening retinopathy. But it is important, not in telemedicine, what we all need to remember is very often there are many patients who are actually screened in using different kinds of cameras, whether it's ultra wide field or standard camera. But what is important is to close the loop and ensure that those who are advised referred to the ophthalmologist actually go and meet the ophthalmologist for further management. We need to remember whenever we use AI that the AI may miss things that a human reader may notice. Suppose if an AI is trained only to identify diabetic retinopathy, it may not identify other retinal pathology unless it is already trained to identify that particular pathology. So image quality also becomes very important for AI. If the image quality is poor, the AI may miss things, particularly with cataract, etc. The image quality is not very good, or the focusing of the is bad. The image quality is not good. AI may sometimes not be able to provide the appropriate output. So here is what I want to know from you all. What do you actually want to look for in your imaging system? What would you like to have in your imaging setup, in your ophthalmic practice? Many of you could be practicing people. Or do you want an ultra wide field view which can capture retinal images, the small pupil, or you just want an affordable, cost effective system or do you want an AI-based system which will give you the diagnosis of retinopathy or other pathology, retinal pathology, or you want a simple, sleek handheld device which can do an auto capture, etc. So many of them, we have mixed responses. Many of them are interested in having ultra wide field view, which can capture retinal images even with small pupils without dilatation. I think that is the way forward. That is the way we are going to look at, because it is going to be easy to pick up many kinds of retinal pathology, not just retinopathy. So I also do definitely look forward to an ultra wide view. So I would like to conclude by saying that definitely retinal imaging is a boon for diabetic retinopathy screening. Both wide field imaging or ultra wide field imaging has a very high sensitivity and specificity for detecting sight-threatening DR. Ultra wide field imaging is very useful in telemedicine because of the speed of acquisition of retinal images, lesser unreadables, and better patient comfort. Wide field imaging with smartphone photographs, which we found in our study, it could detect PPLs in about 30% of eyes, and even PPLs were seen more commonly in people with higher severity of DR, and more PPLs were seen in the supratemporal quadrant. So wide field imaging with less expensive devices can be a cost-effective alternative if you find that ultra wide field imaging systems are expensive in your country. Of course, with use of newer retinal imaging technology, using teleophthalmology, deep learning algorithms, detecting automated detection of PPLs, and automated detection of areas of non-perfusion, that is the ischemic index, we would be able to predict and plan DR management better. Thanks for your attention. This is our team from Dr. Mohan's Diabetes Specialty Center, our team of optometrists and ophthalmologists. Thanks for your attention.
So we have few questions in the Q&A box. I would start a question to Dr. Rajlakshmi, that you had told that PPL signs. Can you elaborate more on the peripheral lesions? I'm sure you can. You have done a study with Dr. Giridhar group. We were part of it together, where we tried looking at the lesion distribution. Though hemorrhages seems to be common, any other observation you have about these peripheral lesions?
What we found was that these peripheral lesions had nothing to do with the HbA1c values or the duration of diabetes. It did not get influenced by any of those systemic factors, although we found that presence of peripheral lesions also correlated with cardiovascular disease, presence of cardiovascular disease. We never correlated with uncontrolled diabetes. It was not correlating with the duration of diabetes, uncontrolled diabetes, or hypertension and things like that. That was a new finding that we found in our joint study with we all did together as a multicentric project. So that was a new learning for us when we did this particular study. And again, grading between the there can be differences in grading between the graders was what we found. That's why I think adjudicated grading becomes very essential, particularly when there are such wide fields to be graded, which is definitely time consuming and it is a tedious task.
Yeah, just one or two points I would like to add. One is definitely, as you rightly said, hemorrhages seems to be a common feature, most common finding. About 10 to 20% cases, the grade of retinopathy may change. I think that is
Yes.
important feature,
Yes.
that you are talking as moderate, it may become severe, or it may become a proliferative disease.
Yeah,
The
very true.
distribution of peripheral lesions seems to be related also to ethnicity, because Paul Alilo group had shown that it's not only hemorrhages, but they even saw the irmas, the venous bleeding, and NVs. However, another study which we have done, where we tried quantifying these lesions in Indian eyes, we did see that we had less of these peripheral lesions, but we had more of exudation. Again, this is exudates were more. This is not shown in other population, probably more of inflammatory mediated. That's one of the reason why in our continent, in Indian subcontinent, use of Ozurdex is much more common. We found more of exudates as compared to the other diabetic retinopathy lesions. Again, the very fact that only 10 to 20% the grade of retinopathy will change. Dr. Professor Srinivas Sadda had actually used the INOOC 45-degree AI algorithm on a wide field image. And he tried looking at, and he
Okay.
showed good performance, though now they have the eye read study where they have tried looking at grading the peripheral. But why it will not matter much would be because the difference is hardly about 10% or 15% will have. So we are used to looking at a AUC of 0.98, 0.99 for diabetic retinopathy. But even if you use no, the algorithm which is developed on a posterior pole, you may still get about 80% accuracy in detecting diabetic retinopathy. So definitely, though it is now we have more studies coming up with AI algorithms which are based on, and I was part of the Tang et al. Study by Dr. Carroll, where we did a multicentric, the 3CNN, and it worked pretty well. There are many of these studies which have come up now. I have one question which is to both of you, and even I will try to answer. This was one of the questions which came that Dr. Rajlakshmi, what you feel is the common shortcoming of ultra, which you feel would be the most important shortcoming of ultra wide field image?
The peripheral distortion and the eyelash artifacts are the most, I think, peripheral, because of peripheral distortion, the superior aspect and the inferior aspect, there are things that are getting missed. And of course, the eyelash artifacts sometimes are bothersome. And again, subtle, very subtle microaneurysms also sometimes we found were getting missed.
I think Dr. Rajalakshmi also has got a large experience of having diabetic retinopathy lesions in pre-diabetes. Do you have any idea about whether these pre-diabetics have more peripheral or posterior pole lesions? I just had this question, just came in mind, because that would be
Yeah.
interesting to look at.
Yeah, we found that those people, that is even before they developed diabetes, we found we in fact did fundus photography for them. And we found that there were a lot of those who had hypertension and pre-diabetes. We found that possibly whether it was related to hypertension, HbA1c little above 6, but less than 6.5 to define them. Those were the people who had peripheral lesions, and people who had hypertension had more peripheral lesions in pre-diabetes,
Great.
even before they develop diabetes.
Dr. Olina, your answer for the common shortcoming, what you feel is the most common shortcoming?
For the wide field imaging.
Yeah.
I think this, especially if we talk about this like more advanced machine and using the angiography, I think that's probably the expenses that's needed to cover this in the daily practice. So more like more available machines would be useful.
Yeah, I think I would agree with both of you. These are definitely important shortcomings. Just to add one, which is important, the art of indirect ophthalmoscopy is coming down. The way we used to make those peripheral drawings, I've shown one of them, which definitely is one of the shortcomings because not all the lesions are picked up on ultra wide field image. It may be RGB or it may be RG. It is still indirect ophthalmoscopy has its own place, especially in cases in surgical retina. Medical retina diseases definitely can be picked up pretty well, but surgical retina, just identifying the lattices or peripheral lesions based on ultra wide field may not be the correct way. You need to definitely, it helps us, but documentation is definitely better. But indirect ophthalmoscopy is something which we should still practice. So we'll come to the last talk of the day. We have Dr. Olena Horzi, who is a UVA specialist and a general ophthalmologist in the network of eye centers in Kyiv, Ukraine. She's also the residency training director at her place, and she's a project lead in the Seva AIDS initiative in Ukraine. And she will be talking to us some clinical studies and case presentations which show the impact of the managing peripheral lesions in the retinal condition. Her focus of talk would be mainly on HIV. Dr. Olna, please.
And again, good evening, morning, and afternoon for everyone. And thank you for this opportunity to present here today. And my talk will be kind of wrap up of our today's session. And again, I'm Olena Horji, an ophthalmologist from Kiev, Ukraine. And I'd like to share our experience for using the Widefield imaging, especially with the HIV patients. So these are my non-existing financial disclosure. So briefly, let's look through the definition, like some basics. It was covered already by previous presenters. Of different retinal modalities that can be used in our clinics. And as a basics, we have conventional imager of posterior pole that shows us the retina within temporal vascular arcades and slightly beyond that. And then we have a Widefield images where we can see retina in 4 quadrants and up to vortic veins. And also we have ultra wide field images where the retina anterior to the vortex veins is also visible. Here you can see 7 conventional infrared fundus images which are used in combination as a standard protocol in ETDRS study, as you all know. And also you can appreciate how much of the retina is missing even using this combination of these 7 standard fundus photos. And this ICG picture shows us the delineation between the posterior pole images, which represent in inner blue circle, as well as a Widefield image in outer blue circle, and the far periphery, which located beyond the anterior border of the vortex veins and can be seen in ultra wide field images. So to shortly wrap up, we have catch some basic definitions. Let's think how much of the retina can be visualized using the ultra-wide field retinal imaging, and it was already covered, so you have a clue. You are all quite right. So the correct answer is D. 200% of the retina is covered by the ultra-wide field retinal imaging. And here we can see the recommendation for definitions of wide field and ultra wide field images according to the International Wide Field Imaging Study that was done in 2019. And here you can see the percentage and the degree to which extend the different regions within the retina, like a posterior pole and mid periphery, and also the wide far periphery that can be seen with the ultra wide field imaging. And also there are different modalities that can improve our diagnostic and thus treatment of retinal diseases located in the periphery. And in terms of retinal images without using the contrast, we have full color images, red-free images, and as well as autofluorescence images. And there are imaging modalities where we use fluorescein or indocyanine green dye to access retinal or choroidal vascular changes. And here on the images, you can show how much more visible the peripheral vascular lesions become if we use angiography in addition to retinal photos. And which patients will benefit from using these Widefield imaging techniques? Vascular changes, such as we see in diabetic retinopathy, as well as retinal occlusive diseases and different retinal vasculopathies, will be much more visible on Widefield images compared to the conventional images that we can make with the fundus photo. And also the peripheral retinal tears and detachment will be visible, as well as the posterior and intermediate uveitis, especially if we talk about pars planitis, where we should see far beyond the vortex veins and up to pars plana, where peripheral retinal leakage will be used not only to determine whether disease and uveitis is active, but also to understand the effect of the treatment that we are giving to our patients. And here I'd like to share a couple of cases how we use the retinal images as a tool for detecting the retinal disease in HIV patients in the resource limited setting that's are present right now. And this special case shows it's not only the clinical application of the technique that we are talking about, but also there is a story behind this case. You see the complaints that this patient started to have. The patient is female, 37-year-old. She's HIV positive. I have a pretty pretty low CD4 count. Her CD4 cell count is 67, and her complaint started with blurred vision in the right eye, which started in February 2022. When the war began, and thus she didn't have any opportunity to see an ophthalmologist. So she was treated in the HIV clinic, and I will talk a bit more about it further, about the initiative on blindness prevention that we have. So this picture was taken by the infectionist and was sent to the ophthalmologist to grade the image. And actually, this is how this patient started to be treated. And the remotely diagnosis of CMV retinitis were thus made, and patient received treatment. So in these pictures, you can see the white on the superior temporal and the temporal part of the retina. You can see retinal widening with the hemorrhages, and image is a bit blurred because of the opacities that patient had in vitreous. So this makes the diagnosis of CMV retinitis. And also we can see the other eye where the retinal scar is presented in the nasal part, which present as an inactive CMV disease at that time. And also this images was taken by infectionist with the camera already mentioned today, with the pristine remedial camera, and was sent to the ophthalmologist to make an evaluation. So at the presentation, patient had an active disease and was remotely prescribed with a treatment. And after 1 month of the treatment, she was again evaluated by the infectionist, and the picture was sent, and we see that disease become inactive, and the scarring process is already beginning. And this patient saw an ophthalmologist actually only 4 months after she was already after the treatment was already started. So this case was managed purely by the telemedicine using the ultra-wide field imaging that we are talking about today. And before I'll proceed to the next case, I'd like to take a moment to appreciate the efforts made by Sieva Foundation in blindness prevention in HIV patients across the globe and also in Ukraine. And our work here started in 2017. And initially it was about the teaching infectionists to do indirect ophthalmoscopy. And we already mentioned today that indirect ophthalmoscopy started to decline because of the presence of this ultra-wide field imaging techniques. So the initial thought was to teach infectionists how to do indirect ophthalmoscopy to prevent blindness in the patient. And here you can see the infectionist. And she was initially trained to do indirect ophthalmoscopy, but after retinal camera became available, she appreciated how much it's easier for her started to be to screen this patient. So since 2022, these retinal cameras was spread across 4 sites in Ukraine, and at that moment more than 500 patients already are screened, and all the images are taken by infectionists and sent to the ophthalmologist to evaluate them. So the other case that you can see is a male, 42 years old, and he is also HIV positive with a low CD4 count, and you can see that he has a high viral load. Also, and he was diagnosed with HIV retinopathy, and this is a disease where wide field imaging also helps, because we can see these small white lesions, which is the cotton wall spot with the ischemic lesion and the microvasculopathy, is located in the center, and we can see that the peripheral retina is free. And there is no lesions there, so it's more characteristic, and it's more it tells us that it's an HIV retinopathy in this patient. And also you can see on the other eye the small cotton wool spot near the optic disc. And also you can see the infrared images of the same patient, and you can appreciate the small ischemic lesions there. And the third case is the female, 25 years old, also HIV positive with very low CD4 count. and she has a retinal widening with hemorrhages again, with a satellite lesion, with a clearance in the center of this lesion, and it's also characteristic for the CMV retinitis. And if this patient would be seen by the ophthalmologist initially, of course it makes sense, and even with the when the fundus land, it can be easily detected. But in the resource limited center, if this patient is treated like an inpatient and cannot go anywhere, this fundus imaging helps a lot. So the infectionist again take this picture, send it to ophthalmologist, and the treatment can be initiated right away. So it's not only about the taking pictures, it's not only that setting diagnosis, but it's also about saving life of this patient with this screening tool. And here is one more question that I'd like you to answer. Please note which of the following condition is most likely to be detected with the wide field retinal imaging. Most of you are right, it's a retinal detachment can be detected. And to conclude, the wide field imaging helps us not only to make a right and timely diagnosis and stage the disease and prescribe treatment and start manage this patient properly, but also to influence on the treatment outcome. And this is a very valuable screening tool, as I think you already get from the slide shown before, is in terms of telemedicine and education and maintaining medical records. It's very valuable for our patients to have the access to those techniques. With this, I'd like to thank you all, and if there is any question, I'll be happy to answer.
Thank you, Dr. Olina. Definitely, it highlighted the role of ultra-wide field imaging and wide field imaging in HIV. Any comments, Dr. Rajlakshmi? You have any comments for Dr. Olina?
I think the work done by Seva and your team is amazing. I think wherein through telemedicine, you have diagnosed timely diagnosis of CMV retinitis or HIV retinopathy is amazing work done by you and your team. And think whether it's this the cottonwool spots indicating of ischemia or the other peripheral lesions, I think it is a great work done by the team, and kudos to your team.
Dr. Olina, I have just one question. Do you have a longitudinal follow-up of these patients? Because it would be the role of ultra-wide field, not only in detecting, but probably the progression of the disease, because sometimes these peripheral lesions do progress, especially ARN and CMV retinitis. It's important to identify whether the disease is progressing. Have you documented any progression and trying to correlate with the systemic condition?
Yeah, we follow up this patient for up to 2 years already when the fundus imaging started. The progress depends very much on the treatment that this patient receives, and as you probably know, the systemic treatment for this patient is way more expensive that anyone can afford here. So I think that's the most important factor that we rely on. The laser treatment has its role in if you pick it up early, which also can be done with the retinal images. It can prevent further spread of this image, but the systemic treatment itself makes it much, if available, makes it much easier.
Thank you. Any other questions, Dr. Rajlakshmi, you have for Dr. Olina? I think I'll just add one comment which I have. It may not be relevant, but I've not done much work on HIV, but we did screen a huge cohort of nearly 2,000 HIV patients with diabetes. And I was keen to know, because HIV retinopathy and diabetic retinopathy, they share a lot of common clinical features. And we did find that this cohort, we also looked into diabetes and diabetic retinopathy and the risk factors. So diabetes is common, and HIV duration seems to be an important factor for development of diabetes. But diabetic retinopathy, to our surprise, was less in this population as compared to the general population. And the only risk factor was the longer duration of diabetes. More recently, there have been evidence that lamivudine, which is one of the important drug for HIV, seems to have some microglial protective role, and there are postulates by Dr. Ambati's group, which they've been trying to use it for treatment of diabetic retinopathy. So maybe because majority of, and lamivudine seems to be the first choice drug in India. That was one of the probable reason we have quoted in that paper. But yes, definitely it seems to capture, and there we had not used a wide field image, but a 45-degree image.
Yeah, I definitely agree. And even to add to this, I think that's the retinal findings that you will see in this patient depends much on the CD4 count. And if you look at the patient with a low CD4 count and which has some opportunistic infection at the beginning of the disease, you will see much more infectious lesions in the retina. And if you will see the patient with a high or intermediate CD4 count, there will be like a general vascular disease as you will see in any other patients. So the CD4 counts matters here.
Dr. Alina, there's one question from the audience. They want to know, was any ocular treatment given to the case 1 HIV patient?
No, she was treated with the systemic treatment only because ophthalmologist was not available at that time. So she firstly saw an ophthalmologist in 4 months after the diagnosis was set with the retinal images. So it was systemic treatment only with the valganciclovir and with the ART treatment itself.
Sure. Dr. Rajlakshmi, there are a few more questions which have come, and I'd like to ask you one of the question which has come: how easy is to incorporate AI into established retinal screening in terms of cost?
Essentially, if there is an integrated AI along with the camera itself, even in primary care setups, AI can be used, or of course, AI can be integrated. It is good to have an EMR system where there is a available EMR system. Also, it is easier to integrate AI solutions into it, wherein the AI can be incorporated and all the images which are automatically fed. The key for any AI to do well, of course, is good, clear fundus photography, I think, becomes key. A good quality fundus image becomes important. There are different kinds of AI which are available. Some are just by on rental basis, like for a month to screen just about 100 images. You want to have AI, it's not cost to cost, like per patient basis, per month basis, per week. Suppose you're going to have a camp, and only for the camp you want to have AI. Also, there are AI algorithms which are available that way also. It is easy. Only thing is, there are a lot of AI solutions available. A validated AI which has a good sensitivity as well as specificity is important, because with the amount of algorithms which are available, it is important to choose the right algorithm for which has been validated to use.
Yeah. I'll just add to one point to it. See, one good news is that majority of these AI algorithms are today available with the cameras. So I would strongly advise that ask the vendor the camera which you have, definitely they can upgrade it with an AI algorithm, because majority of them will find a market along with a camera. Example like Remedio has its own AI, which is very well validated. We have Zeiss, which have used Selena. We have Forest Camera, which is using Google and their own algorithm. So many of these algorithms, which have shown good sensitivity, good AUCs, have actually been integrated into existing cameras. And good thing is it's not coming with a very high cost or extra cost. So I would encourage that if you already have a camera, you can talk to your vendor and ask them if they can upgrade it with the AI solution, because that is something which can be done. And there's a question, where can I buy a Remedio phone camera? I think go to the website and you'll find all the details. Again, Dr. Alina, you can probably answer that. When can the Optomap RGB be utilized within the ultra wide field imaging?
No. I'm looking for this question. Can they? I think a different condition requires looking at different settings and at different modalities that has. So I do not see if there is any clear application in the uveitis cases for that, but in vascular cases, in vascular condition, you can appreciate that.
Absolutely true. So I think Dr. Rajalakshmi did mention that the peripheral lesions with that green hue sometimes is difficult to see. And we are more used to seeing a natural retina color, and seeing those we can identify. We had that 15% disagreement that probably can come down by this. The downside, as I told, is that the blue light is not that great to the patient cooperation, which sometimes we say that even small pupil, photophobic patients, kids, we are still able to use the RG, but RGB, that comes with a challenge that we will not be able to use that because that would be causing more glare and patient cooperation would be less. There is another question, I think, Dr. Rajalakshmi, I can ask, though it's not much related to the talk, but why does a cataract surgery accelerate progression of DR?
Essentially, cataract surgery, there could be some pre-existing DR even before cataract surgery. So it's essential to try to look at the fundus prior to planning the cataract surgery, or do an OCT for people with diabetes to ensure that there's no macular edema prior to planning cataract surgery. The inflammatory process during a cataract surgery itself per se, or suddenly if there's a sudden glycemic control, say for the sake of cataract surgery, if the sugar levels are brought down suddenly, or the inflammatory process during the cataract surgery itself can also cause worsening of diabetic retinopathy. So fundus reassessment post cataract surgery, checking for macular edema. It's always, if there is pre-existing retinopathy, treat the retinopathy prior to cataract surgery is what we follow in our setup.
I perfectly agree with you. I think the major cause being the inflammatory response and the vascular changes which happen. And one of the thing, inflammatory response itself increases VEGF, and that is one of the reason of no progression. It itself, cataract surgery is oxidative stress, and these diabetics, they have a compromised oxidative status that itself again can promote progression. Blood retinal barrier breakdown, if it's a complicated cataract surgery, can add to the complication and again help in the progression of diabetic retinopathy. And there's also alterations in the ocular perfusion, which has been documented after a cataract surgery, again leading to a increased progression. And some of them, they do talk about the light exposure during cataract surgery, again having some roles, but there are many of these hypotheses, but inflammatory being the most important one. Yeah. Uh, One of the doctor asks Dr. Olina that what is the alternative step since CD4 count is not available specifically in HIV patients?
So let me specify the question. What this alternative how to evaluate patient alternative if
If you don't
count
have
is not
CD4.
available.
Correct.
That's a tricky question, but anyway, looking at in the back of the eye is the best solution that you can have for this patient. So see the retina as frequent as possible, and the other thing might be a viral load, but it depends on the treatment itself more than shows us the probability of having the retinal changes. So if the patient have comorbidities, if the patient has some opportunistic infection, it requires more and more retinal screening as much as frequent as possible. But evaluation, the CD4 count itself is essential for treating this patient and understanding the prognosis. So better to get the CD4 count known.
Yeah. There is a question in Spanish, and to be very true, I'm not, so I just tried translating it. And what it means is wide field imaging in children, is it advisable? Is anesthesia necessary? and in which retinal pathology it is most useful? Yeah, so definitely Widefield imaging is recommended now in pediatric cases. It has role in ROP, retinoblastoma, many of the retinal dystrophies, as I told, it helps, and especially autofluorescence in these dystrophies plays an important role in diagnosis. There are contact-based system, and I would say even the non-contact, rather than GA, even using a flying baby position to take optos imaging. I think LV Prasad Eye Institute has come out with a nice atlas using optos for ROP, showing all the stages. Even in our OPD nowadays, these babies, rather than doing a contact ret cam where baby is crying and it's pain, sometimes using optos with a flying baby position does work well. Anesthesia is definitely not needed. A topical anesthetist, if you are anesthesia, if you are using a contact system, is all what is sufficed. You don't need to give a general anesthesia in these cases. I think we'll go to the last question which we have, and that's the $1 million question to both of you. Which is your preferred Widefield imaging device? I know this is a difficult question, but let's see. Dr. Olina, what you would like to tell?
Probably for ophthalmologists, eyes and hands and doing indirect ophthalmoscopy is probably
Yes.
the best tool to detect everything that you have, but it has a steep learning curve, and it takes time to get used to it and to have the proficiency. Anyway, I'm happy to routinely use the Remedia camera right now, and I'm very much fan of like alternative solutions to get it easier and cheaper for our patients. Also, I have experience working in the size machine, and it also works well, and it allows combining OCT as well as the ultra wide field imaging as well as angiography. So I think whenever you have routinely in your practice, I think it will be beneficial for doctors and patients also. But don't forget about the indirect ophthalmoscopy.
Yeah.
Yeah, but the main advantage of imaging is documenting. Nowadays, it becomes as in indirect, we are able to see. But if we don't document, then that is where I think imaging plays a role. When we find it and you document it, becomes what is advisable these days whenever you treat your patient. So it's better to document. That is where I think ultrawide, whether it is RG or RGB or irrespective of the field of view, as long as we are aware regarding the presence of peripheral lesions also, and not just central lesions for diabetic retinopathy or other disorders, I think that becomes important. And again, if the cost of the cameras become lesser, it will be useful for various countries to also start using ultra-wide field imaging in practice. What's your take, Rajiv? Would you like class or?
I will give the talk. I'll give my answer, but I had one question. One person wanted to know where is my HIV and diabetes article. So you'll soon see it in ophthalmic epidemiology. It's been accepted. I've just corrected the proof. So you'll soon see this article in ophthalmic epidemiology. So given the choice at our institute, being a tertiary care, we have 3 or 4 devices. We have Spectralis, we have Optos, we have Clarus, and RetCam. So I was talking about Optos. We use it more commonly in our OPD. Clarus is something where if you're looking at the posterior pole lesions, you want a higher magnification. My AMD patients, I prefer that. And Spectralis, I limit to my wide field FFAs. Wide field, especially when I'm doing a oral FA, where you definitely want a confocal image and a nice resolution. You get a very good quality images when we use Spectralis. But you need to find a mix match and find your tool which works best for each of these diseases.
There is a question on using eye supplements. Yes, and of course, more than eye supplements, it is the diabetes control, which becomes key in the treatment of retinopathy rather than eye supplements. And AI is available in portable cameras, medias, AI is available with Remedio fundus camera.
There is probably a question, what's the specific treatment of retinopathy?
Yes.
If we are speaking about the HIV retinopathy, there is no specific treatment. If the question was about that, because the controlling the HIV itself and prescribing the ART treatment and having the viral load being reduced, it
Sorry.
helps with the HIV retinopathy itself.
I think thanks all for participating in this webinar. I hope it was very useful for all of you. Thank you.
Thank you. Thank you all.
Thank you to the panelists
Hello.
also. Thank you.
Thank you.